بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته، والصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. إن شاء الله اليوم نتكلم عن بقية أو الأجزاء المتبقية من الأسيد بيز بالانس أو الأسيد بيز ديستربنس النفرولوجي. إن شاء الله يمكن نحاول نقفل الموضوع الأسيد بيز من A to Z، وهناخد المواضيع كلها إن شاء الله بإذن الله. أي شابتر هناخدوه من A to Z إن شاء الله. النهاردة نكمل السلسلة بتاعتنا بتاعت الأسيد بيز. هنتكلم النهارده عن الريسبيراتوري اسيدوزيس. هنعمله رابيد ريفيو just to refreshment. I know this is not many cases or not our problem as a nephrologist, but the main issue in ICU. But we should know also all acid based disturbance to interpretation او تعمل تحليل الاي بي جي او غازات بالدم لما يجي لك عموما كقريل نفرولوجي او تخصص نفرولوجي. نتوكل على الله وإن شاء الله الجميع يستفيد اليوم وتكون إن شاء الله مختصرة ومفيدة وعلى الكلينيكال بوينت. بسم الله الرحمن الرحيم. قال سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. بسم الله الرحمن الرحيم. قل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. صدق الله العظيم. بسم الله الرحمن الرحيم. إن الله وملائكته يصلون على النبي يا أيها الذين آمنوا صلوا عليه وسلموا تسليما. صدق الله العظيم. اللهم صل وسلم على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. قبل ما نتكلم عن الريسبيراتوري اسيدوزيس، تعالى نشوف البيزك بتاع السي او 2 ميتابوليزم ان جنرال. اولا النورمال انديفيدوال في الشخص الطبيعي السي او 2 بالانس از مينتيند. ثاني اكسيد الكربون ده بيحصل له بالانس and maintained by the following mechanism: by either number one by CO2 production and CO2 transport and CO2 excretion and the control of ventilation via central nervous system. يبقى احنا عندنا production, transport, excretion and control via our central nervous system. CO2 production is produced by metabolism of carbohydrate and fats. This source of CO2. Heavy exercise generates several fold of higher quantity of CO2. Even exercise also بتطلع لك CO2 especially مع exercise more than a resting state. Approximately around 15,000 millimole of CO2 are produced daily. يبقى انت في النورمال كده بتطلع 15,000 millimole CO2. ما حد يسألك النورمال بتاع CO2 الشخص الطبيعي بيطلع حوالي 15,000 millimole of CO2 are produced daily. Lung are only organs that excrete all CO2 that is produced. يبقى مشكلتنا في السي او 2 لو حصل سي او 2 ريتنشن، ده مشكلته فين؟ تبقى المشكله عندنا اساسا في اللنج، لان هي الوحيده المسؤوله عن الاكسكريشن بتاع السي او 2. CO2 excretion زي ما قلنا الالفولار ventilation is the major determinant of CO2 excretion. ده بيعتمد على الالفولار ventilation for excretion. Decrease in alveolar ventilation like I am COPD and we'll come to the causes now. Decrease in alveolar ventilation lead to retention of CO2 resulting in increase of total body CO2 balance. Other determinants include blood flow through the aerated lung, diffusion of CO2 from the capillary to the alveolar space and physiological dead space. ده برضه من الحاجات اللي هي بتساعد في السي او 2 اكسكريشن، اللي هم الالفولار سبيس اللي بيحصل فيه الريشن وكده، والفسيولوجيكال ديد سبيس. كل ما بيزيد الفسيولوجيكال ديد سبيس او البيب مع الفنتليتور، كل طبعا ما بيقل الريشن في المكان ده وبيعمل ريتيننج للسي او 2. طبعا كلنا عارفين البافرنج حته السي او 2 اكسكريشن. احنا عندنا في الانسايد اور بادي الهيدروجين ايون combine with bicarb and lead to carbonic acid. Formation of carbonic acid. This carbonic acid easily transferred to lung and dissociated to water and CO2. This CO2 will be water and CO2 will be excreted via lung, exhaled by our lungs. Lead the mechanism from our body. Hydrogen combined with bicarb lead to carbonic acid. Carbonic acid easily transferred via the blood, small capillaries, via lung tissue, and inside the lung carbonic acid will be dissociated to water and CO2, and this will be easily exhaled by our lung. Other protein buffering, hemoglobin is an excellent intracellular buffer because of its ability to bind with the hydrogen. له قابلية طبعا ان هو بيعمل binding مع الهيدروجين forming a weak acid called carbonic acid. As the hemoglobin reach the lung, it reverses this and now bind with oxygen, releasing CO2 and الكربونيك acid دلوقتي هيتحول إلى water and CO2 and they will be exhaled by our lung. This then break down into CO2 and water with the lung breathing out CO2, decreasing the amount of acidity in our body. CO2 again summary. CO2 is byproduct of cellular metabolism زي ما قلنا من الكربوهيدرات والفات. CO2 is a primary stimulus to our breathing. لذلك العين ان هو السو بي دي ما ترفعش، ما تحاولش تحط على الاكسجين، تعلي الاكسجين عن 92%. 88 to 92% is okay. Otherwise if you will increase oxygenation, you will decrease CO2. CO2 here is the main stimulus to our breathing via central nervous system. Increased metabolism should increase respiration due to the higher concentration of CO2 produced. Increasing alveolar ventilation to lower CO2 concentration occurs in a minute in response to decrease in pH, acidity of our blood. CO2 is transported as a carbonic acid to the lung, and inside the lungs, this carbonic acid H2SO3 will dissociate to water and CO2, and CO2 will be exhaled out our bodies. CNS control of ventilation, normal individual, variation in the PCO2 and partial arterial oxygen, BO2, and the pH, PCO2, PO2, and the pH are minimized and kept within normal limit by respiratory control system, which includes the following: either chemoreceptors, sensor, or central controlled medulla and the bones, central of respiration, present in medulla and the bones, and respiratory muscles is a factor also. This is the main controller of our breathing. General mechanism of respiratory disorders. Respiratory centers feel to appropriate process physiological data related to gas exchange and inability to change ventilation in response to appropriate signals from the respiratory center. This will come to all these causes now. Control of ventilation, either central input or peripheral input. Central input, central chemoreceptors is located in medulla, is highly sensitive to a change in pH, either by increase or decrease, and this will stimulate the medullary center to respond either to increase the breathing or decrease the breathing. And the cerebral cortex also via chemoreceptors, any pain and stress, this will stimulate or decrease the respiratory via stimulation our medullary center. Other stimulatory pneumotaxic apneustic center also located in the bones. Any pain or any stress also can stimulate that, any trauma. And progesterone receptors location identified is this also another receptor stimulate our medullary respiratory center. peripheral either chemoreceptor located. الchemoreceptor قلنا في البريفرال بتبقى موجوده فين؟ between الكاروتيد and aortic arch detect any change in the PCO2, pH, BO2, and this will end by stimulation. This is the main, and this is the main. This is located here in the medulla, here located between the carotid and aortic bodies, and it all both detects any change in CO2, pH, and BO2, and they end by stimulation of our medullary center. And another G receptor, stretch receptor, irritant receptor, all this can stimulate our medullary respiratory center. Control of ventilation, if we have high PCO2 and low pH and low PO2, pain and anxiety, pulmonary edema, histamine inhalation, any chemicals, high progesterones, as we mentioned before, all this will go to medullary, stimulate the medullary center, increase ventilatory drive. Low PCO2, high pH, this will inhibit or decrease the ventilatory, will send the signals to the medullary respiratory center, and this will decrease our ventilatory drive. And this alveolar ventilation equation, this is normal physiology when our pH decrease from metabolic process. With chemoreceptors will transmit information to our medullary centers of respiration, and this will increase the ventilation. This increased ventilation will end by decrease partial arterial CO2. And this, by this equation, this will lead to decrease the partial arterial CO2 will return back our pH back towards the normal. And we'll come to alveolar ventilation equation, and we'll come to this later. Alveolar ventilation is partial CO2 and the volume or the amount of CO2 produced and tidal volume divided by tidal volume and the dead space, volume of dead space, because the dead space, when you will increase dead space, this space already no aeration, and if this increase will increase amount of CO2 retained in this area because no gas exchange. And the etiology of partial increase in CO2 either lower in respiratory rate, lower tidal volume, high in dead space, or the volume of dead space is high, and the high volume or production of CO2, and these two rare causes, but the most common cause, low respiratory rate and low tidal volume. This is the tidal volume, this is amount of air exchange per minute in our normal person. CO2 transport, as we mentioned before, in our bodies, hydrogen ion combine with the bicarb and lead to carbonic acid, H2CO3. H2 is easily transported to our lung via blood capillaries and will end by easily dissociated in our lung into water and the CO2. CO2 transport, CO2 is produced during metabolism, is transported by the blood. The mechanism of transport of our CO2 is a common question, either plasma and red blood cells to the lung via pulmonary arteries. The PCO2 difference gradient between the tissue and the alveoli, difference between the CO2 in the tissue and the alveoli around 6 millimeters. The red blood cells CO2 is converted to carbonic acid, as we mentioned before. In the red blood cells, CO2 is converted into carbonic acid in the presence of carbonic anhydrase. The carbonic acid is dissociated into hydrogen and bicarb inside our body. It is the bicarb that diffuse into the plasma via chloride bicarb exchanger and carried to the lung, where it is converted into carbonic acid and dissociated to water and the CO2, and this CO2 will be exhaled easily via our lung. We'll go now to our topics. This is the respiratory acidosis. We'll go to introduction. Respiratory acid based disorders is طبعا قبل ما اتكلم عن acid based disorders لازم يكون في ايدك اي بي جي، تمام، مع اللايتس مع الكرياتينين مع كل شيء لازم يكون معاك اي بي جي. Respiratory acid based disorders are divided into respiratory alkalosis, which can be acute or chronic, and respiratory acidosis, which can be acute chronic, and respiratory alkalosis, which also can be acute and chronic. The diagnosis is made after obtaining arterial blood gases, as we mentioned before. Respiratory acidosis is also known primary hypercapnia. Primary hypercapnia. Respiratory acidosis معناها ان انا عندي CO2 عالي and due to an increase in carbon dioxide tension in body fluid. The metabolic compensation is increased in serum bicarb. واحنا بنشوف العين ده مع العين الكونجستيف هارت فيلير، عين الفوليوم اوفرلود اللي عمال تديله لازكس فبتعمل انت ميتابوليك الكالوزيس وتدخل عين في ايه؟ compensatory respiratory acidosis. The increase in more pronounced in chronic acidosis, oxygen administration is critical in management of respiratory acidosis. We need oxygen to get rid out our CO2 from our patient body. Respiratory alkalosis or primary hypocapnia. احنا قلنا respiratory acidosis primary hypercapnia، لكن respiratory alkalosis is primary hypocapnia is to decrease in CO2 tension in bodily fluid. The metabolic compensation is decreasing the bicarb. The decrease is more pronounced in chronic respiratory alkalosis. Rapid correction of respiratory alkalosis should be avoided, and the underlying etiologies should be addressed first. Okay, take care from that point. A respiratory acidosis is acidemia, pH less than 7.35. This means acidemia due to increase in CO2 tension in the bodily fluid. If the pH decreased less than 7.35 due to increase in CO2 tension, this means acidemia. It is characterized by increased arterial pressure of CO2, partial arterial CO2 more than 45 and normal 35 to 45 millimeter mercury due to alveolar hypoventilation, primary hypercapnia. ده اللي بتأدي لك البرايمري هايبركابنيا في النهاية. In respiratory acidosis the rate of CO2 production is unmatched by alveolar minute ventilation. alveolar minute ventilation اللي هو الريت بتاع الاريشن اللي بيحصل للجاز او gas exchange in our lung per minute. The lung excrete about, as we mentioned before, 15,000 milliequivalent of hydrogen ion daily as carbonic acid. As we mentioned, hydrogen bind with bicarb lead to carbonic acid H2CO3 will go to lung dissociated to water and CO2 resulting from lipid and carbohydrate metabolism. CO2 يعني الريزلت بتاعه جاي منين؟ من الكربوهيدرات والليبيد ميتابوليزم زي ما قلنا قبل كده. This about 200 times the amount of renal excretion. About 200 times of renal excretion. Respiratory acidosis, as we mentioned, can be acute or chronic. In acute respiratory acidosis, bicarb increase 1 milliequivalent per liter for every 10 millimeter mercury increase in the partial arterial CO2. In chronic respiratory acidosis, more than 24 hours, like our hyponatremia, but hyponatremia 48 hours. In chronic respiratory acidosis, bicarb increase by 4 milliequivalent for each 10 millimeter mercury of partial arterial CO2 increase. The increase in bicarb is called metabolic compensation. In chronic respiratory acidosis, the metabolic adaptation takes 3 to 5 days. In chronic respiratory acidosis, I need 3 to 5 days to compensate our chronic respiratory acidosis. In simple acid-base disorders, both partial arterial CO2 and bicarb move on the same direction. Same direction means bicarb up, partial arterial CO2 up. This means we have simple acid-base disorder. Both are up, respiratory acidosis. Both are down, respiratory alkalosis and metabolic alkalosis. And both are down in respiratory alkalosis and metabolic acidosis. Again, both up, CO2, bicarb up in respiratory acidosis, metabolic alkalosis. Both will be up. And in respiratory alkalosis and metabolic acidosis, both will be down. Both will be down. Okay. Movement of الحركة بتاعت البيكارب and the CO2 in opposite direction. This means mixed acid-base disorders. لما تلاقي البي CO2 طالع لفوق والبيكارب نازل لتحت، عندنا هنا mixed acid-base disorder. والعكس صحيح. For example, ABG, chronic respiratory failure due to chronic COPD, pH 7.35, acidemia, and CO2 70 is high, bicarb 37. The diagnosis is chronic respiratory acidosis, simple acid-base disorders. The BCO2 up and the bicarb up, this simple acid-base disorder. The bicarb 37 is expected due to metabolic compensation of chronic respiratory acidosis. Bicarb will increase by 14 millimeter increase in the PCO2. Since the PCO2 is 70, is expected bicarb will be 3 multiplied, increase now by 33 multiplied by 4, 30 above the 40. Normal CO2 is 40. Now we have 10, 10, 10. Yes, 3 10, 3 multiplied by 4, 12. 12 multiplied by 24, our basal, our normal bicarb, this will be 36, which is very close to actual value of our equation, 37 milliequivalent per liter. This is a very nice example. Just if you can take a picture and repeat again. Now let us to take example of the same patient after hospitalization with sepsis. Now pH is acidotic, pH 7.12, PCO2 70, bicarb is 22. We have here PCO2 is high, bicarb is low. This now reverse now, not in the same direction, means mixed acid-base disorders. This we have here, this respiratory acidosis, a pH of 7.12 is indicative of severe acidemia. In this patient, partial arterial CO2 and bicarb moved in opposite directions. This is indicative of mixed acid-base disorders, namely chronic respiratory acidosis due to COPD and metabolic acidosis from sepsis. Note that bicarb is 22, which is 14 lower than the expected value of 36. With decline in bicarb result of metabolic acidosis. Another good example. Etiology of respiratory acidosis, either from decreased rate of depth of breathing, obstruction of air disease like COPD, decreasing gas exchange. It will end by accumulation of CO2 and respiratory acidosis. common etiology of respiratory acidosis. The most common obstructive lung disease, COPD, asthma, and drugs like alcohol, narcotic, benzodiazepines, antihistamines, gabapentin, antidepressant, antipsychotic. All this will end by obstructive lung disease and central hypoventilation, and various brainstem lesion, obesity, hypoventilation syndrome, central hypoventilation syndrome. Also, neuromuscular diseases like spinal cord, nerve, Guillain-Barré syndrome, neuromuscular myasthenia gravis, muscles, polymyositis, and other poor respiratory compliance, decreased lung compliance, interstitial lung disease, acute lung injury, ARDS, acute respiratory distress syndrome, pulmonary edema, decrease in chest wall compliance like kyphoscoliosis and hypermetabolism, increase in the volume of CO2 or CO2 production, extreme fever, prolonged seizure, and hyperelimination. All this can lead to respiratory acidosis, either central hypoventilation، عندك مشاكل في البرين او في السنترال بتاع الريسبيراتوري سنتر، نيوروماسكولار عندك مشاكل في المصل او الريسبيراتوري ماسل، بور ريسبيراتوري كومبلاينس، عيان انترستيشال لانج ديزيز، ريسبيراتوري ستريس، بالمونري ايديما، هايبر ميتابوليزم، عندك عيان عنده حراره عاليه، برولونج سيجر، and hyper elimination. The most common, I will concentrate on the most common to put in your mind, respiratory acidosis. I will see commonly COPD or bronchial asthma, drugs like alcohol, narcotic, all this central hypoventilation or central respiratory depression, alcohol, narcotic, benzodiazepines, antihistaminic, gabapentins, and various antidepressant, antipsychotic, obesity, hypoventilation syndrome, obstructive sleep apnea. Most of all this lead to respiratory acidosis. COPD and respiratory acidosis, we have two types. It's the most common type of respiratory acidosis. We have two types: chronic bronchitis. We remember this chronic bronchitis, blue bloater, and emphysema, pink buffer, and the blue bloater, chronic bronchitis, emphysema. COPD and respiratory acidosis, air will start by airway inflammation in the home. This one, blue bloater, chronic bronchitis here, and emphysema here. Chronic bronchitis, what happened in chronic bronchitis or blue bloaters is patient with airway inflammation in chronic bronchitis lead to increased airway mucus, and this will lead to airway obstruction, hyperinflation, positive index respiratory pressure, diaphragm flattening, and decrease tidal volume, and lead to decrease alveolar ventilation, lead to decrease more partial arterial CO2 accumulation. Here, by emphysema, destruction of lung parenchyma, lead to decreased airway traction and decreased surface area of alveolar capillary membrane. Decreased airway traction here lead to airway obstruction, same scenario here. And this decreased surface area of alveolar capillary membrane, all this decrease alveolar ventilation, and all this lead to accumulation or increase the partial arterial CO2. The sensitivity to change in the BC2 in central respiratory center, both this also decreased sensitivity, whatever the cause, will also end by increase this partial arterial CO2. Drug overdose, drug suppressing respiratory drive generally first lower respiratory rate and only at higher level and lower tidal volume as well. Risk of significant respiratory acidosis is relatively low when only single drug is present, but each additional drug that added synergistic effect impact on the ventilation. Here, the one drug only is no major change, but two drugs will increase more synergistic effect for central respiratory center depression, drug overdose. Many drugs overdose you can read here, especially barbiturate, alcohol, chlorhydrate, propofol. Take care from all these narcotics. Maybe will end by, especially in COPD patient or patient with respiratory problem. Obesity, hypoventilation syndrome, defined as the combination of obesity and chronic hypoventilation while awake that occurs in the absence of other explanation. Hypoventilation occurs due to poor compliance of chest wall, lead to restrictive lung disease, and decrease central responsiveness to partial arterial CO2 and partial arterial O2. Obesity hyperventilation syndrome, as we mentioned, maybe the part from obstructive sleep apnea, but obstructive sleep apnea not a part of obstructive hypoventilation, obesity hypoventilation syndrome. Obesity hypoventilation syndrome, frequent complication of this syndrome, chronic hypoxia or hypoxemia, pulmonary hypertension, right side heart failure, predisposition to development of hypercapnic respiratory failure also. In general, again, just to by another shape, just a cause of acute respiratory acidosis, either depression of the medullary respiratory center, drugs as we mentioned, anesthesia, sedative, opiates, cerebral trauma or infarction, central sleep apnea, cardiac arrest, failure of motor function of respiratory muscle and chest wall, drugs like succinyl, choline, and courier aminonucleic acid, high cervical cordotomy, myasthenia gravis, Guillain-Barré syndrome, and status epilepticus and tetanus. All this will end by acute عيان جاله epilepsy, عيان في seizure, عيان حصل له تروما للبرين أو المدلري respiratory center, عيان داخل في tetanus, كل Guillain-Barré syndrome, cardiac arrest, all this acute and medication also. Acute botulism poisoning, familial hypokalemic periodic paralysis, severe hypophosphatemia, airway obstruction, aspiration, laryngospasm, severe bronchospasm, obstructive sleep apnea, ventilatory defect, and flail chest, also all this acute respiratory acidosis. Pneumothorax, hydrothorax, acute respiratory distress syndrome, acute pulmonary embolism, acute pulmonary edema, severe asthma, severe pneumonia, mechanical ventilation, increased production of CO2, due to high carbohydrate feeding and fixed minute ventilation. All this lead to acute respiratory failure, chronic depression of chronic respiratory acidosis, like depression of medullary respiratory center, chronic sedative, opiate addiction, brain tumors, primary alveolar hypoventilation, obesity hypoventilation syndrome, bulbar poliomyelitis, failure of motor function, of respiratory muscle and chest wall, spinal cord injury, multiple sclerosis, muscle dystrophy, amyotrophic lateral sclerosis, myxedema also can lead to chronic respiratory acidosis. Take care from a patient with hypothyroidism, poliomyelitis also, diaphragmatic paralysis after surgery, airway obstruction, COPD is the most common cause of chronic respiratory acidosis, COPD and obesity hypoventilation syndrome, and medication. Don't forget that, ventilation defect, hydrothorax, fibrothorax, kyphoscoliosis, interstitial lung disease, severe chronic pneumonia, extreme obesity. Causes again, and this is respiratory acidosis, depression of respiratory center, as we mentioned, pulmonary and neuromuscular disorder. Respiratory acidosis, as we mentioned, may be acute or chronic respiratory acidosis result in when the rate of CO2 generation. هي طبعا acidosis بتحصل لما بيحصل respiratory بالذات لما بيحصل exceed generation, exceeds the ability of the lung to secrete this production. Example, pulmonary disorders, as we mentioned, bronchial asthma most common, COPD most common, adult respiratory distress syndrome, hypoventilation, as in patient with mechanical ventilation, and permissive hypercapnia. Example of neuromuscular disorders are cerebrovascular accidents, sedatives, and myasthenia gravis, and multiple sclerosis. Depression of central nervous system, medullary respiratory center, either infection, encephalitis, CVA, and general anesthesia, alcohol, sedative overdose, heat trauma, cerebral edema, pulmonary cause, COPD, asthma, laryngospasm, and angioedema, atelectasis, pneumothorax, ERDS, pulmonary edema, pulmonary embolism, pulmonary fibrosis. Neuromuscular as myasthenia gravis, multiple sclerosis, muscular dystrophy, Guillain-Barré syndrome, tetanus, status epilepticus, amyotrophic lateral sclerosis, poliomyelitis, toxin medication such as succinyl, choline, and organophosphate. Muscular as hypokalemia. Hypokalemia lead to also problem and hyperkalemia and hypophosphatemia. That are related to energy and muscle weakness, respiratory muscle weakness, mechanical ventilation, permissive hypercapnia and hypoventilation, miscellaneous obesity, hypoventilation syndrome, kyphoscoliosis. Diagnosis. Diagnosis of respiratory acidosis made after obtaining ABG. In respiratory acidosis, we have acidemia 7.35, the pH less than 7.35, and partial CO2 more than 45 millimeter mercury. You should ask also after ABG should ask electrolyte panels, calcium, phosphate, magnesium. Kidney function test, CBC also should be obtained. Knowledge of bicarb allows circulation of metabolic compensation. History of physical exam is critical for our patient. Medication can be provided. Important clue to your diagnosis. Patient also requires chest X-rays, most important, further pulmonary testing such as pulmonary function studies, and chest CT should be done also for our patient case according to case by case basis. We have one case patient with terminal COPD, pH 7.32, acidemia, PCO2 is 83, acidosis already is high, with bicarb also is 41 is elevated. The patient was chronic respiratory acidosis. Chronic, as we mentioned, each 10 millimeter increase in the PCO2, bicarb will increase by 4. Therefore, for P partial arterial CO2 83, we know normal P partial arterial CO2 is 40, and this patient now increased by 4, 10, 10, above our normal 40. 410, this means our bicarb normal 24 multiplied by plus 4 multiplied by 4 will give you 40 milliequivalent. This means we are close to the bicarb value in our chemistry profile. This indicates that the patient simple acid-base disorders, chronic respiratory acidosis. Another case, the history is significant for nausea and vomiting. His medication includes, we'll come to this medication. Medication include furosemide, initially BG 7.33 acidemia, and PCO2 also is high, and bicarb is 35. The patient had acute respiratory acidosis through myasthenia gravis. Expected metabolic cons with acute respiratory acidosis from myasthenia gravis. The expected metabolic compensation should be resulting bicarb is 27, which is with the maximal response of 30s, but our patient 35. Bicarb is 35 indicated concomitant metabolic alkalosis due to vomiting and diuretic use. Therefore, the patient has mixed acid-base disorders because this not going together in the same direction. Compensation of simple acid-base disorders. This is the most important slide in our presentation today. Just take a picture to keep in your phone or your small pocket notes as you like. This compensation of simple acid-base disorders. Just to keep this in your, I will keep my, I think that's okay. Keep this in your phone. Our metabolic acidosis. Metabolic acidosis means mechanism. Low bicarb will with low pH both in the same direction. Compensation for that, partial arterial CO2 multiplied by equal 1.5 multiplied by bicarb plus 8 plus or minus 2, or another way, partial arterial CO2 will be 15 plus bicarb, or partial arterial CO2 last 2 digit of pH. You understand this? If I have pH 7.21, this means this is a partial PCO2. Decrease in the partial CO2 equal 1.2 in multiplied by decrease in the bicarb. This is all this way to do compensation for our metabolic acidosis. Compensation limit partial CO2's maximum decrease is around 10 millimeter mercury. Okay, he will partial CO2 will not decrease more than 10 millimeter mercury. In metabolic alkalosis, we have pH is high, bicarb is high. Our equation for compensation for partial arterial CO2, 40 plus 0.6 multiplied by bicarb minus 24. 24 is the normal person bicarb. Partial arterial CO2 maximum limit compensation 55. You will not go more than this. Respiratory acidosis, we have low pH, high PCO2. For acute respiratory acidosis, we mentioned for every 10 millimeter mercury increase in the PCO2, there is 1 millimeter milli equivalent or millimole increase in the bicarb. Chronic 10 millimeter mercury increase in the CO2, 4 milli equivalent per liter increase in the bicarb. In the acute, maximum bicarb increase is 13, chronic maximum 45. This compensation limitation, our limits. Respiratory alkalosis, pH is high, PCO2 is low, and acute, each 10 millimeter mercury increase in the PCO2. decrease in الBCO2, there is 2 milliequivalent decrease in bicarb. In chronic respiratory alkalosis, for every 10 millimeter mercury decrease in الBCO2, there is 5 milliequivalent per liter decrease in bicarb. In an acute, maximum decrease in bicarb is 18, and the chronic maximum decrease is 12. You can listen again and read again and take a picture and keep in your phone. Clinical manifestation, either neurological, cardiovascular, neuromuscular, respiratory. Respiratory increased respiratory rate, hypoventilation and hypoxia, neuromuscular seizure, cardiovascular decrease, blood pressure because cardiac depression from acidosis, and dysrhythmia with warm flash skin. Neurological, we have lethargy, confusion, dizziness, and coma. As I mentioned, nausea, vomiting, restlessness, and headache, confusion, seizure, and coma. All this a clinical manifestation. Decrease cerebral blood flow, increase acutely due to cerebral vasodilatation of the capillaries and the venules. This cerebral vasodilatation is mediated by nitric oxide. Intracranial pressure, hypercapnia, increase intracranial pressure due to increased blood volume and increased vascular pressure caused by vasodilatation. Increased blood pressure and heart rate, secondary to increased sympathetic tone, also lead to increased blood pressure with tachycardia. Cardiac output increase, also coronary blood increase, sympathetic tone. Cardiac output increase, also coronary blood due to hypercapnia and vasoconstriction due to increased sympathetic tone. Occurs in patients with acute respiratory acidosis. Arrhythmia is also common in respiratory acidosis. As regard renal effect, include renal vasodilatation with mild hypercapnia and vasoconstriction at partial TrCO2 more than 70. RAS stimulation stimulated by hypercapnia, induced sympathetic tones, antidiuretic hormone secretion was also increased. RAS stimulation, sympathetic tone, antidiuretic hormone all increased. And regard also the feature of respiratory acidosis are function of severity and the rapidity of onset. Acute respiratory acidosis can cause dyspnea, confusion, psychosis, headache, irritability, and anxiety. Seizure are seen in severe cases. Chronic respiratory acidosis is associated with tremors, gait disturbance, somnolence, and memory loss. Hypercapnia is usually associated with hypoxemia. And this our table again. And the feature of respiratory acidosis are function of severity and rapidity of onset. We mentioned that already. Hypercapnic encephalopathy, when some patients will go to delirium and then agitation, distress, and coma. Is due to progressive CO2 narcosis, CO2 narcosis, which result in coma. High CO2 lead to vasodilatation of the cerebral blood vessels and subsequent increase in intracranial pressure. In severe cases, papilledema can be seen on endoscopic exam. A patient with chronic hypercapnia can have sodium and water retention, especially if they have cor pulmonale. Patient with chronic hypercapnia can have sodium and water retention, especially with cor pulmonale complication. Severe hypercapnia can cause cardiac dysrhythmia, low cardiac output, and hypotension. Severe hypercapnia lead to cardiac arrhythmia, low cardiac output, and hypotension. Diagnosis. History, cough, short of breath. From history, the first thing you will examine your patient. We take a history of cough, short of breath, fever, asthma, congestive heart failure, or trauma, or due to head or back, drug use, and other condition should be obtained. This is the most important critical take history of cough or short of breath with fever. This is the signs of chest infection. History of asthma, COPD, congestive heart failure, trauma to his head. This will affect central respiratory depression, medullary central respiratory stimulation or depression, or back for spinal cord, drug abuse or narcotic drugs or other condition should be obtained. Should include vital signs, breathing pattern, body habitus, accessory muscle use in your examination, auscultation of the lung for crackles, wheezing, tactile teeth, then trace of any mouth of any foreign material, chest exam for shape and the perimeters, movement of diaphragm, cardiac exam for AC3 and AC4 for congestive heart failure, abdomen for muscle use, lower extremity edema for upper extremity clubbing, and good neurological exam also. We need arterial blood gases, especially if pH less than 7.25, acidemia and elevated bicarb, and elevated partial arterial CO2 characterized by acute respiratory acidosis, pH CO2 like that. Serum chemistry, calcium, magnesium, phosphate, hemoglobin. Slight increase in serum sodium is observed 2 to 4 milliequivalent per liter. A slight increase in serum potassium, also slight decrease in the chloride because chloride entry into red blood cells in exchange of for bicarb, chloride shift. Hyperphosphatemia is common due to release of phosphate from tissue, not present in chronic respiratory acidosis. Calcium, magnesium usually normal, but a slight increase has been reported. Normal anion gap, acidic urine pH less than 5.5, chest X-ray, and the ECG for any dysrhythmia or any pneumonia or any lung finding, pulmonary edema or pneumonia. Calculation of alveolar arterial gradient for gas exchange. Our treatment, the mainstay of treatment is addressing the underlying cause of respiratory acidosis. Should treat underlying cause, bronchial asthma, COPD, drugs, whatever. Pneumonia is pulmonary edema, whatever the cause. It's critical to know that respiratory acidosis associated with hypoxemia and requires O2 administration. This is critical in management of your patient. Acute and severe respiratory acidosis require immediate action because it can lead to life-threatening and deep coma. Some patients require endotracheal intubation and mechanical ventilation to correct acidemia and hypoxemia. Hypercapnia in patients with COPD should not be corrected aggressively. Our target 88-92 oxygen saturation. O2 administration is done cautiously, otherwise you will make your patient respiratory, because the CO2 is a respiratory stimulant. If you correct your respiratory acidosis rapidly by high flow oxygen, this will end by your patient will go to deep coma. Better to keep your oxygen saturation. Preferred oxygen saturation around 88 to 92, especially with patients with COPD. O2 oxygen administration is done cautiously to avoid worsening hypercapnia resulting from depression of our respiratory drive, CO2, because the CO2 is our respiratory drive and our stimulants to our awakeness and consciousness. Rapid and aggressive correction may lead to seizure, cardiac arrhythmia, and decreased cerebral perfusion. Some patients develop hypercapnic coma. A reasonable goal of is lowering the partial arterial CO2 to the baseline. Some critically ill patients have mixed metabolic acidosis and respiratory acidosis and may need sodium bicarb infusion. Alkali treatment in this setting remained an issue of controversy. The goal is never to normalize the pH and the bicarb rather than to reach a reasonable target pH around 7.2. That's okay. Low tidal volume ventilation is utilized. Low tidal volume ventilation we can use by BAP, CPAP, and we'll see. Alkalemia causes respiratory depression via prevalent central chemoreceptor. Frequent monitoring of ABG and electrolyte is needed in this setting. In this patient, potassium should be depleted with potassium chloride. should be repleted with potassium chloride. لازم تعوض للبوتاسيوم بتاعك. Moreover, diuretic and corticosteroid should be decreased or discontinued, okay, for our patient. Patient with chronic respiratory acidosis treated with oxygen, especially patient with COPD, oxygen, bronchodilator, either inhaled and systemic steroid, and smoke cessation. Pulmonary consultation is often required. Please just to call pulmonary for any respiratory acidosis. To avoid post-hypercapnic metabolic alkalosis, patients should have adequate chloride and potassium to enable renal excretion of bicarb, which has increased to metabolic compensation of our respiratory acidosis. Some clinicians use acetazolamide in patients with post-hypercapnic metabolic alkalosis if iatrogenic from our Lasix. We saw that already. Most commonly in patients with congestive heart failure. Acetazolamide is bicarbonate and calliuretic. بيعمل excretion طول bicarb and البوتاسيوم من اليورين. Require frequent take care from acetazolamide for bicarb and the potassium, and with frequent potassium monitoring and aggressive replacement, it should only be used by clinical familiar with it. Maximum 3 days, don't increase more than this. And start by 250 BID. Just we're using but just per oral. I am not using IV. Usual dose 250 to 500 BID 3 days, 3 times daily, or BID I will use only for 3 days only. One study with double blinding randomized trial conducted 15 French intensive care unit ICU's patient, enrolled 382 COPD patient on mechanical ventilation with simple or mixed metabolic alkalosis. Active arm patient received large dose IV acetazolamide 500 to 1000 twice daily. Acetazolamide did not change the duration of invasive mechanical ventilation, viral endotracheal intubation, or tracheostomy, which was the primary study outcome. The small reduction in picarb 0.8 milligram per liter in acetazolamide group was statistically significant. يعني IV or oral مش هتفرق كتير، بس الافضل ان انت تستخدمه oral لان الاي في مش هيفرق معاك في الانتوبيشن والتراكيوستومي. Development of metabolic alkalosis in patient with chronic respiratory acidosis lead to depression of respiratory drive. Take care from the development of metabolic alkalosis in patient with chronic respiratory acidosis lead to depression of respiratory drive. This makes weaning from mechanical ventilation is more difficult. Another retrospective studies, 84 COPD patient on mechanical ventilation post-hypercapnic metabolic alkalosis was seen around 20% and lead to increased dependence on mechanical ventilation and longer stay in intensive care unit. Take care from metabolic alkalosis. With Giver et al. Also showed the arterial pH is important prognostic for survival. Study already done by him and showed this by the group and showed 139 episodes of acute hypercapnia type 2 respiratory failure in 95% of 95 patients. This occurred in 25% of episodes of pH less than 7.25 as opposed to 7% of the episodes of pH more than 7.25, but this occurs with low pH 7.25 and compared by 7% with pH more than 7.25. وأتمنى يا رب تكونوا استفدتوا شيء اليوم، ونسألكم الدعاء بالتوفيق والسداد، ولا تنسونا دائما من صالح الدعاء، ونترككم في رعاية الله وحفظه، ولا تنسوا دائما الصلاة والسلام على حبيبنا محمد صلى الله عليه وسلم، والسلام عليكم ورحمة الله وبركاته.